Hi folks, this is Dr. Rob Cywes. I am the Carb Addiction Doc. And today I'm going to explore my opinion, my perspective, our practice's perspective of the management of diabetes, particularly type 2 diabetes, in the ketogenic space. And I think that I've seen polar opposite viewpoints in terms of how to manage diabetes and what our endpoints, what our objectives are with the management. So there are really three different ways in which we manage diabetes. Just to throw one out of the window very quickly, the standard glycemic index way of managing diabetes, which most endocrinologists do, is they treat the amount of carbohydrates you eat and they use medications to treat what you're eating, which is absolute lunacy. It's absolutely ludicrous. They don't care that much about blood sugar, and they want an A1C below 7. They're happy with that. They make a diagnosis of diabetes above 6.5. Below that, they don't care. That is lunacy. When you're just so far removed from reality, when you are so far removed from reality, I don't even want to engage with that methodology. If that's what your current endocrinologist is doing, come and speak to me, come and speak to one of us. But that is a way to die of your diabetes. So leave that alone. Within the ketogenic space, we've become brilliant at helping to improve diabetes. But there really are two concepts that I'm at the Low Carb Boca USA, Low Carb USA conference today, and a brilliant talk was given. But I sat and thought about that and compared it to how we do things. And I want to, within our space, we both believe fundamentally in the same things, but the methodology and the emphasis is a little bit different. So this is within our space. It's all collective. Either methodology works, but I want to juxtapose our methodology and our thinking to what I heard yesterday on stage from a brilliant, brilliant person. So the change in philosophy within the ketogenic space is, number one, that the problem is carbohydrates. And you want to eliminate carbohydrates from your diet, which is what the standard glycemic index endocrinologists do not do. So the shift is eat carbohydrates and use drugs to manage the blood sugar. Here we're saying don't eat carbohydrates. And it is quite true that if you don't eat carbohydrates, your blood sugars over time get better, your insulin resistance reverses. And at first, a lot of these patients with high A1Cs above 6.5 are often on medication. So the push is don't eat carbohydrates, and then let's see how quickly, as soon as your blood sugars come down, as soon as your A1C goes below 6.5, let's get you off medication. And the thrust is no carbohydrates, off medication with an A1C below 6.5. So those are the criteria of success, because it's true. When your A1C is below 6.5, you technically don't have type 2 diabetes, okay? And when you're off medication, and you can come off medication, at least in theory, when your A1C is below 6.5, that is a win. And I understand that, and I love that. But our philosophy is different. So to juxtapose against off medication and my A1C is below 6.5, those are not our goals. Those are not our metrics, because those are not the problem. So let me give you insight into how we look at things. In our practice, the only thing that matters is your average blood sugar. We don't care why it's up, and we don't care what happens to bring it down. And we've got methodology, stepwise methodology to bring that A1C down. So I'm going to ask you a question. And this is an important way of thinking, changing your way of thinking about diabetes. Okay? And I'm going to use an analogy here. Ask yourself, what is a normal blood alcohol level? What is a normal blood alcohol level? Oh, I don't know. It's so obvious, folks. A normal blood alcohol level is 0. No magic to that. Okay? No magic to that. A normal blood alcohol is 0. Now, in the state of Florida, the law says that if you're driving and your blood alcohol level is above 0.08, you can go to jail. But what's happening between 0, a normal blood alcohol level, and 0.08? So if I'm driving and I'm at 0.07, I don't go to jail, but I sure as hell am not sober enough to drive, and the risk of an accident is much, much higher. That difference between 0.7 and 0.8 or it doesn't matter that much to my quality of driving. It's just that the law has set one number, but 0 is the normal number. And really what we try to achieve, if you're an alcoholic and you've had DUIs, you don't want to be driving at a 0.04 or 0.05. You want to be driving at a 0 and never go above 0. So the target of an AA program is a 0 blood alcohol level. Well, exactly the same with diabetes. Okay? So what we've got to look at is, what is the problem? What is the problem with elevated average blood sugar? The problem is that the elevated blood sugar levels causes, and this is where it's causal. And I've shown this in the laboratory. That little Ph.D. I have here did that. It is causal. As your blood sugar level goes above a certain threshold, it triggers swelling and inflammation of the endothelial cells and the underlying basement membrane of your blood vessels. So elevated levels of sugar create inflammation, and your blood clotting cascade then reacts to that inflammation and lays down clot and damages those blood vessels. Or you can get scarring of the blood vessels. How do we know the blood vessels are scarred? When there's fat and lipid and calcium, which is all part of the clotting cascade. Calcium is factor 2, the lipids are the final layer. Those are the markers, the hallmarks, the residual of chronic inflammation in your blood vessels by elevated blood sugar. Okay? So that's the danger. And the risk it poses is stroke, neuropathy, heart attack, and occlusion of blood vessels with ischemia. That is the vascular risk of elevated blood sugar. Okay? So at what level? What is a level at which, just like with 0 alcohol in your bloodstream, what is that level for blood sugar? Because you have to have sugar in your bloodstream. Your body dies if it's too low. You can have seizures, you can die. So there is absolutely an average threshold that is required. And the blood sugar number in US metrics, the ideal blood sugar, the normal blood sugar, is a blood glucose level of 83. But that's a spot number, so 80 to 85. The second part is that a normal A1C at which your average blood sugar is really not posing an inflammatory risk to your blood vessels is 5.2. A1C of 5.2. But we diagnose diabetes at 6.5. So the reason I use the alcohol analogy is for exactly that. What's happening in your blood vessels between 5.2 and 6.5? Well, inflammation in an escalating scale. So, my A1C is 6.1 or 5.7, and I'm off medication. Win, win, win. Yes, it is a partial win. But you've still got that inflammatory cascade happening. You're still at risk for cardiovascular disease. You're still at risk for the neuropathy. You're still at risk when your average blood sugar is high enough to cause those elevated A1Cs. And that's a marker for me of insulin resistance. Yes, it is a thing. Insulin resistance is a factual thing. One of the next videos coming up will explain that. However, my treatment goal in my practice is to get your A1C, help you to get your A1C as low as possible. Ideally at or below 5.2, and certainly above 5.5. To my mind, the regimen has failed if your A1C is above 5.5. Ideally, it should be below 5.2. So the question then is, strategically, how does our strategy to achieve those numbers differ from other people's numbers? So the only thing that matters is your elevated blood sugar, and it doesn't matter why it's up. And obviously, being in ketosis where you're burning fat is the ideal. How do you get there? So the first therapeutic paradigm is to remove carbohydrates from our diet and increase the fat content, okay? So that your body is desiring fat and ketones as a primary fuel source, not sugar. So we restore what we call insulin sensitivity, where insulin is the hormone that regulates blood sugar, and insulin is able to get that sugar into the cells that store it. The liver, and the biggest storage of glucose is actually the muscle cells, and then the liver and the fat cells will convert some of it to fat. So the objective is to use diet at a first level, and this is a multi-pronged approach, at the first level to eliminate carbohydrates, to eliminate the source of sugar going in. Now, there's a caveat to that, because a little bit of sugar is actually required, and this is what we didn't know a few years ago. A little bit of sugar is required to trigger GLP-1 that triggers insulin. So as a physician, I've got to understand that complexity and help you to know where your insulin level is. So at first, we eliminate carbohydrates to create insulin sensitivity. But then when you become insulin suppressed, where you're so fat adapted, you may not have adequate insulin to clear the sugar that the liver is providing, because the liver produces sugar for your bloodstream. So we may have to trigger insulin release, not to add sugar to your bloodstream, but a little bit of sugar in the gut will trigger GLP-1, which triggers insulin. Sophisticated, for those of you who don't understand that, that's my job. That's what we do in the office, okay? We help you about that continuum. But the second thing is this. If you're doing that, if that strategy is working, great. So low carbohydrate diet, the second thing you want to do is go long periods of time without eating, which is the intermittent fasting. Intermittent or extended fasting, because what happens in those prolonged fasts, 16, 18 hours, if you're eating twice a day, or 23 hours, like I often do, eating once a day, it gives your body a long period of time to deal with the carbohydrates you've eaten and to release fat, which suppresses blood sugar. And remember, it's the average blood sugar. I don't mind if your sugar goes up from time to time, but it's the average blood sugar that defines A1C. And we want that average to be low, and the longer you go without eating in a healthy system, the lower your blood sugar goes. Never too low, but we'd like to get into the 70s and 80s. And you've got to be in ketosis to be able to do that in a healthy way. So the first one is getting rid of the carbohydrates. The second one is to get used to prolonged fasts and be in ketosis. And that, to a certain extent, does require eating a higher fat percentage than a higher carbohydrate percentage. Because here's the other interesting thing. In our diets, no matter who you are, vegan or carnivore, the amount of protein we eat is relatively fixed. Obviously, the vegans are eating a little bit less, carnivores a little bit more, but it's fixed around 20 to 25%. And that is really doesn't change very much. The big things that alter is the other 80% that comes from carbohydrates or the 80% that comes from fat. And we manipulate that ratio. That's part of our dietary work in a ketogenic diet, is really playing with a fat carbohydrate ratio. And there are different stages where we do it differently. And again, that's why a practice like ours has benefit over the internet, because we can individualize where you are along that journey, and it changes over time. There's not one right answer. We've got to know where you are and give you guidance based on where you are, not where some blowhard gum flapper on the internet would have you, okay? The third component of utilization and management of blood sugar is physical activity. And it's the frequency, not the intensity, that matters the most. Remember, your muscles are the largest storage place of glucose as glycogen. They're also the largest users of sugar when you are not dormant, when you're not a bump on a log. So to the extent you can, regular physical activity is also a part of managing blood sugar. Creating a place so that your sugar goes to your muscles for storage and then gets used by the muscles, rather than being turned into fat or elevated blood sugar. And particularly on a ketogenic diet, where you're eating a lot of fat, your body has less and less use for that sugar, so the sugar hangs around in your bloodstream, it just sits there. And one of the other key things when you get sophisticated about this is to look at your protein-fat ratio. Because if you're eating a little bit more protein, the body has to use that extra protein. Now, we don't know exactly what that threshold is. We can figure it out for each individual, but everybody has a different one. Sean Baker has a very, very different threshold for protein being used for protein than I do. My threshold's much lower. I'm kind of more bump on logish. I work out, but not as much as Sean. So he can turn way more protein into protein. My protein requirement is much lower because the excess for both of us becomes sugar and feeds our blood sugar. Okay? So now remember that. Now we're going to segue to the next level. And there are times when diet, exercise, and low-carb diet, exercise, and intermittent fasting is not enough to keep your blood sugar low. And if the only thing that matters is blood sugar, here's where I deviate very heavily from my colleagues. Because blood sugar is so dangerous in terms of inflammation, let's add medication in to bump insulin production or to lower that blood sugar, to block the increased release of sugar from your liver. We slow down the effects of glucagon and gluconeogenesis. And there are some dietary changes we can make, but there's medication that we use. And there are medications that we use to lower the addition of sugar to your bloodstream or to lower the blood sugar. And I don't demonize those medications. We'll use them, from metformin to the GLP-1 agonists to some of the DPP-4 agonists, even to insulin if we need to. But there's a range of medications that we can absolutely use, because all that matters, at least by my viewpoint, is your average blood sugar. So we don't demonize blood, and it's not rah, 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 you're off medication. In fact, the interview on this channel with Tim Noakes was kind of an epiphany, but it supported what we do. Tim was a type 2 diabetic 12 years ago, got into diabetes remission, but he still tracks his blood sugar very closely, and anytime he sees a little elevation, he'll use some metformin to bring that down. Because he, like I do, have a philosophy that it's the blood sugar that matters, not the medication that you use to bring it down. So that for me is the fundamental difference. The fundamental differences between other workers in the space is, number one, my target is an average blood sugar, an A1C of 5.2, ideally, and a blood sugar in the 80s, ideally in the 80 to 85 range, with maybe a few early morning spikes up into the 90s, but never above 110, and always being in ketosis. That's what we strive for. And how we get there is cumulative. Diet, intermittent fasting, exercise, and then medications. And as part of that, your blood work tells us where you are. Your insulin production capacity, your liver lipids. We've got to look at all that blood work to determine where is this person right now in the continuum of change, and how do we take them from here to the next step. That is our focus on diabetes management and within the ketogenic space. And we're all friends, we're all on the same page, but we have shifted. Maybe we're more radical, maybe we're more aggressive. But in those higher A1C ranges, even below 6.5, that we call that the insulin resistance phase, that is still where we're getting hyperglycemic injury to your blood vessels. And there have been several experiments in animals as well as humans where we've proven that that damages the endothelial cells. That's what I did in my Ph.D. In my master's thesis, we ran sugar at various concentrations into livers, and we examined the blood vessels, and we examined them for inflammation and for early changes. And we demonstrated that even slightly elevated blood sugars created that damage in whole humans, in pigs, in rats, and in isolated livers. And folks, you know, when I did that research, 1990 to 96, in defiance of the glycemic index people. In fact, David Jenkins, the guy that wrote in 1981 the Sentinel paper on the glycemic index, was on my Ph.D. committee. And our data defied everything that they were trying to build. So we knew it then, but we've struggled to implement it. That's what I do in my practice. And if you're interested in that, at least let us evaluate where you are. At least let us give you some guidance to how you can improve things if you want to go down that trajectory. If you just want to use drugs, it'll help, but it's really like fighting in a thunderstorm. It's not going to help you to deal with what you're putting in your mouth. No drug, no drug, no drug, not even injection of insulin can on average control your blood sugar if you're insulin resistant and consuming carbohydrates, which is the standard philosophy of the endocrinologists out there. No drug has that capacity. So you're fooling yourself if you can eat carbohydrates and use insulin to control it. That's like smoking 3 cigarettes and going for a run to breathe out the nicotine. Lunacy. But that's how we manage it. And our goal of management is to protect you from harm, help you to protect yourself from harm. So we use behavioral change, and we also will use medication as indicated. Now, the final discussion of that, how the hell do you know what your blood sugars are? That is where CGMs come in. And to my mind, the most accurate one right now, and we've used them all, and obviously there's a cost issue, but the Dexcom G6 and the soon-to-be-released Dexcom G7 is by far the best, most accurate form of monitoring your blood sugars. Keto Mojo is the best way to see right now if you're in ketosis. I do declare that I have a relationship with Dexcom. We are doing some studies with them, but my promotion of Dexcom has nothing to do with my relationship with the company. We were promoting this and using this way back before. And our relationship with Dexcom is to provide additional scientific proof of our methodology. Folks, if I've made you think, if I've made you ponder, or if you disagree with me, leave comments below. There's a whole comment section. Leave comments below. And I usually get out there and I answer a lot of them. But let's have this debate within ourselves, within our own group. Okay? And if you want an appointment, give us a shout. We've got what we call the bat phone. You can text, you can WhatsApp, you can leave a message, a voicemail, 561-517-0642. And we have a whole team that helps you to do this. If I've made you think today, if I've made you think differently about your diabetes, or even if you don't have diabetes, about your elevated A1C above 5.2, I've done my job.